Okay, and our next presenter is Liz Margolis, founder and executive director of the National LGBT Cancer Network.
Just, hi, what do I do?
This advances your slides.
Thank you, that's all I needed. I only speak Mac, I'm sorry. Let me start by thanking all of you for watching that video of Jay Callio. As you might have suspected, he's no longer alive. But it was his wish that his legacy be the story that was his transition and healthcare experiences. So it would mean a lot to him that you watched it and took that in. So thank you. Okay, start the clock. I'm going to be addressing LGBTQ people with cancer especially. And so the first question people ask me is, does it really matter? Or as I put out to my audiences when I speak, is a lump a lump a lump, or does it matter who the lump spent Valentine's Day with? And I'm not going to ask you to raise your hands, but nearly everybody says a lump is a lump. And I then spend the rest of my presentation saying, no, it matters who the lump spent Valentine's Day with. People move along a little when I go to the second question. What if it's an ovarian tumor and it's in a transgender man? Does it matter now? And yes, it's true that the surgeon who's going to remove that tumor is going to do the same thing he, she, they would have done. They might follow the same procedure, but it's really important to know who's going to take that person home, who's going to do the follow-up care, what kinds of things are going on in that person's life, do they have support, and if so, from whom? So it really matters. We cannot separate the disease from the person it occurs in. And if I'm saying that it's this important to know who LGBT patients are, even for the surgeons, how come we don't know? And it's because most forms don't give people a chance to disclose. Only some people can you tell by looking. And far too rarely are healthcare professionals and social workers, all allied health professionals, asking people to bring their whole self in. To go back to the previous presentation, I want to be seen for all of who I am. Yes, I am here as a white 66-year-old lesbian New Yorker. I want to be seen for all of me. And if we're leaving that part out, we are not seeing who our people are. So this is from research that my organization did about how people disclosed. And I'm not going to read the slides, but as you can see, if they were out to their health team, most of it was because they brought the subject up themselves. That is wrong, people. That is not the way it should be. It is the provider's job to create a welcoming environment and the provider's job to invite patients and clients to bring their whole selves into treatment. What we also know from this research is that LGBT people who were partnered were twice as likely to bring it up. But we've also found from our research that many people who said they'd been out their whole lives leapt back into the closet for cancer treatment because the only good hospital near me was a Catholic hospital, or a fear that the homophobic surgeon would leave some of my lesions behind, or the homophobic nurse would make me wait longer for my pain meds. So let me just do a quick, I'm sure it's a review for all of you, definition of what I mean by LGBTQ and all the other letters. It's really two different categories that come under one umbrella, one describing sexual orientation and the other describing gender identity. The important thing to remember here is that if you know somebody's sexual orientation, you know nothing about their gender identity, and vice versa. So sexual orientation is about who we're attracted to, and those terms in the acronym are lesbian, gay, and bisexual. The important thing here is that these are identity labels. These are not descriptions of behavior. There was a survey in New York City that asked men who identified as heterosexual it turned out of those people, 10% had had sex with a man in the previous year. And for lesbians who identified as lesbians, 8% of them had had sex with someone in the last year. And face it, I don't know you people, but if all you ever had to do was have an attraction to someone of the same sex and someone of the other sex and maybe a little sexual encounter, almost all of us are bisexual. So these are identity labels. What we often really need to know is what people's behaviors are, because that tells us a lot about their risks. Gender identity, obviously we all have a sexual orientation. We also all have a gender identity. That's the persistent internal feeling of being male, female, both, or neither. I was assigned female at birth, and I still identify as female, so I am cisgender. Transgender people identify as a sex other than the one they were assigned at birth. the important thing about this slide, which is a takeoff of a Fenway slide, I want to give them credit, is that it's not about what's in people's underwear, although that is totally fascinating and it's the first thing everybody wants to know. But that's not what decides if you're trans or gender nonconforming. It's who you feel yourself to be. So a patient can have a beard and say her name is Mary, and that's good enough for me. She's Mary to me. I don't even care if her insurance documentation all says that her name is Mark and she's male. We made these posters, and you can find them for free because cancer treatment is considered to be scientific and gender-free, but it's actually very gendered. And I'll go over this a little more, but people's gender expression might be different for LGBT people. After breast cancer, for example, many lesbians choose not to have reconstruction and don't wear a wig, so that when a lesbian walks into the women's bathroom with a flat chest and a baseball cap, people shriek. This is how cancer is generally understood as a continuum, but I think that this is not helpful for understanding the LGBT cancer experience because we have the same challenges at every phase on the continuum, which is about disclosure and fear of discrimination and lack of data. This is where I think cancer really lives, at the intersection of discrimination, barriers to care, and uneducated providers. Discrimination first. Everyone thinks we don't have to worry about LGBT discrimination since the passage of marriage equality. Wrong. In 2014, lesbian, gay, and bisexual people were the largest target of hate crimes. We've been surpassed by African Americans, but please remember we have intersectional identities, and many African Americans are LGBT people. But even as a group, going back to like the intersectional identities, we are not at equal risk. You can see here that Black trans women are at the greatest risk, and they're at the greatest risk of being shot. Let me just stress that one more time. Trans women are shot because they are transgender, killed because they are transgender, for no other reason. Transgender people also, 70% have faced harassment at bathrooms. And this is a health problem because as a result, people have chosen to not drink water, so they never have to use a public bathroom, which leads to dehydration and kidney problems, etc. These are 3 studies which you should read that all show that discrimination is not just unpleasant and unfair, but is actually bad for your health. The bottom one is unbelievable. Well, the first one shows that policy has an impact on health. If you don't live in a state with protective policies, you're 5 times more likely to have 2 or more mental disorders. And the last one says that if you live in a community with high LGBT bias, you will die 12 years younger. Discrimination is taking 12 years off people's lives. What are they dying of, you ask? Homicide, suicide, and heart disease. So yes, there are individual risk behaviors. And yes, LGBT people use tobacco at higher rates, use drugs and alcohol at much higher rates, more sexually transmitted infections, and we see obesity and eating disorders among young gay men and among lesbians. But it is not just this. This is, I think, what most people would prefer to focus on. So the Affordable Care Act has been a greater benefit to the LGBT community than the general population, and still we're twice as likely to be uninsured than our non-LGBT peers, and less likely to have a regular provider. This is a large Harris Interactive poll that found that 75% of lesbians, and these were primarily white, middle or upper class, and highly educated lesbians, 75% of them were delaying health care. The first 2 reasons were about cost, and the second 2 reasons were about previous negative experiences or fear discrimination. So you see I'm building a case here for increased risks and lower screening rates. And then we come to the uneducated providers. I think most people know here that the average training in medical school in all the years is 5 hours, much of that on HIV, which is important, but not the only thing that's important. Nursing skill, 2 hours. So it's no surprise that half of all transgender people have to teach their own doctors how to treat them. Those are the doctors who let them stay, because 19%, that's about 1 out of 5, trans people have been turned away by a provider simply for being trans. Like, I don't understand your body, you need to see an endocrinologist. And if you saw one of the other films we made, the woman says, I came because I have a cough. But they're like, I just don't want to go near you. So just in case you think that the bias is long gone, this is from a 2016 study, and the same is true for nurses. That the explicit bias is they will say, I prefer not to treat LGBT people. These are young people. These are first-year medical students in 2016. Let me just contrast that with recent studies that came out of the UK and the US of people between 13 and 26 years old, and less than half, only 48% of those people identified as exclusively heterosexual. Now, again, that's about sexual orientation, not gender identity, but that means that less than half of the people we will be working with identify as heterosexual, and we see that the gender possibilities are exploding at the same time. I think I already said that. Okay, so do I really know that we have more cancer? We have some studies, and you can see some things here. But because none of the tumor registries collect information about gender identity or sexual orientation, we are left hidden in the data. And you know how important this data is. For example, we know that white women are more likely to be diagnosed with breast cancer, but black women are more likely to die from it. I can tell you that we smoke at rates that are 40% higher than the general population, but I can't tell you anything about the rates of lung cancer in LGBT people. And then once diagnosed, we face additional challenges. More likely to have distress, report fair or poor health, higher bother scores for gay men with prostate cancer, and general lower satisfaction with care. Now, understand that this might not match the scans and blood work that the providers are using. This is the patient experience, and I don't care how well you think I'm doing, this was horrible for me. Okay, so in that research that I referred to earlier, we asked people at the end, if you were to give a class on, these were LGBT cancer survivors across the country, an online survey. If you were to give a class on LGBT people with cancer, what would you want to say? And 88% of the people who took a survey, you don't want to give one extra second when you do a survey. They took the time to write stuff out. And it floored me. I mean, this is the work I do. I couldn't believe it. And so we wrote a report, and you can find it on my organization's website. But we organized it into themes. And the first was that everybody started out wary. As I said, fear of discrimination and homophobia. You might have avoided the healthcare system and not been really good about getting your cancer screening, but you are just thrust into the system immediately once you're diagnosed with cancer. And that disclosure is not a one-time event. There are many providers. People have up to like 24 people that they're interacting with when you think about like MRI technicians, et cetera. And each time people said, I had to weigh a cost-benefit analysis of whether it was worth coming out. But they all had the anxiety of the procedure, and on top of that, anxiety about disclosure. And as I was saying earlier, cancer treatment is gendered, no matter what they say. So let's just look at where breast cancer, I just took these off the internet. Breast and GYN cancers are often treated at, people think it's really welcoming to call them women's cancer centers. But you can imagine what it's like for the trans guy with ovarian cancer to walk in with his girlfriend and everybody assumes she's the patient. This is profoundly alienating. I mentioned this earlier, that many lesbians are rejecting reconstruction. And part of it is they don't feel like they need to do it to feel beautiful or sexy, and why have extra procedures when they don't need to? But I think that it is not being offered enough as a healthy, beautiful alternative, equally as valuable, even for young people. I use this picture with this person's permission, by the way. The other thing is that our support systems do not look like mainstream support systems, where most people have their partner and their parents. Many LGBT people are alienated from their family of origin because they are LGB and or T. And LGBT people are also far more likely to be caregivers. We are caring for our neighbors. We are caring for our families. We are caring for our friends, like we saw in the early years of the AIDS epidemic. And so people they list who their support system is. It's like my psychotherapist, my ex-lover, my best friend. That's who's taking care of us. And there are not services for people like this in hospitals. There's not enough talk about the sexual implications of cancer treatment on LGBT sexuality. And we see this especially with prostate cancer and gay men, because for anal cancer, you need a more rigid erection, and for anal receptive partners, most of the stuff they're talking about has nothing to do with them. If you want to learn more, you can go to our website, www.cancer-network.org, and you can see this best and promising practices throughout the cancer continuum. We indulge the cancer continuum here and do a lot of like how-to kinds of things. Did it with a minute to spare. Thank you. That was like 40 slides. They said it couldn't be done.